Hello, colleagues. Hello, dear participants. I'm Dr. Casimir Manzengo, the hepatitis focal point for Afro region. Welcome to this session on promoting hepatitis B PMTCT in Afro region, experience from the frontline implementers. Why we are now focusing on PMTCT, as you know, in 2020, the world has reached the ambitious target of 1% for hepatitis B prevalence among children under 5, and all the regions have reached this objective, except the Afro region. And in the Afro, we have only 11 countries who have reached this target. So we are thinking that it is possible for other countries to do the same efforts to reach these ambitious targets, which is very important to be sure to be in the good line for elimination in 2030. So it is why the regional director is calling every countries to make efforts for PMTCT implementation about hepatitis B. And today our session will have three main parts. After the first presentation, we'll have a partners panel, followed by the countries panel, and will end by a Q&A session. It is a virtual session, so you can put your question and comments in the chat box. Also, you will have the French and English interpretation. No problem for this. We have colleagues who are working on it. Now I'm going to deliver the first presentation on where are we on hepatitis B PMTCT in Africa. So slide please. Thank you. Slide please. So we are now talking about hepatitis B PMTCT in Africa. I'm Kazim Manzengu, the focal point for the Afro region. Slide, please. Okay. As you know, we have about 300 million chronic hepatitis B cases in the world, and 1 out of 4 of them are are in Africa. Slide, please. And concerning the disinfection among children under 5, we have about more than 6 million of infections of chronic hepatitis B, and 7 by 10 are in Africa. So I think that it is a big problem for us to be concentrated on this issue among children under 5. Slide, please. Slide, please. Okay, as I was saying that at the end of 2020, the world had reached the ambitious targets of 1% for prevalence among children under 5, 1% or above. And here you can see that all the regions have reached these targets, except in the Afro region, where this prevalence is 2.5%. Slide, please. And concerning the proportion of SBS antigen positive infants born from the mothers, we can see that we don't have enough data from the countries. Rwanda, where we have piloting the elimination validation guidance, there were no data. We have two studies conducted in DRC showing that we have 0% of transmission when the program is well implemented. We can see this project AVERT in DRC conducted on 2021, and in Mozambique another project with MSF showing that we have just one positive case among from 134 pregnant women who were infected by Hep B. Slide, please. And concerning the hepatitis B birth dose introduction, we have 14 countries in Afro region, and the last one now is Burkina Faso, who is going to implement the hepatitis B birth dose. But as you can see, the coverage remains low for most of the country, except Senegal, Algeria, Cabo Verde, and Sao Tome. Slide, please. And we have five main intervention to go to the hepatitis elimination. We have the infant vaccination, we have prevention, PMTCT, we have blood and injection safety, we have harm reduction, we have diagnosis and treatment. And now we are focusing on PMTCT, prevention of mother-to-child transmission. It is what we are discussing now. Slide, please. Given the guidelines from WHO, we have four main activities in the PMTCT implementation. The first one is the serological testing. We are using RDT hepatitis B surface antigen for all pregnant women to see where are positive. And the second step is the maternal assessment. So for this, we are using HBV DNA or antigen envelope, hepatitis B envelope antigen, RDT, or where we have the clear sign of cirrhosis, we can also take the decision. And after this, we have the third step. It is maternal intervention. We are using tenofovir at 28 weeks until the birth, when the pregnant woman is eligible. But if the DNA is more than 200,000, we go through the tenofovir ad vitam. And the last step is the infant intervention using hepatitis B birth dose vaccination plus the routine vaccination for all children. All children. Slide, please. We should now keep the momentum for PMTCT because PMTCT is low-hanging fruit for hepatitis elimination. As you know, we have antenatal care services available in all our countries. We have also some progress with HIV and syphilis PMTCT. We have also the immunization program going in the all our countries. We have also infrastructure, human resources, lab in our country, so we can build on it. We have also some initiative like the involvement of first ladies for in free shine. We have also the civil society for very active on HIV, so we can build on it. We have also financial partners like Global Fund, PEPFAR, Gavi, who are on the field, so we can build on it. And generally, also in our countries, pregnant women and newborn are prioritized. So we can also take this opportunity to be sure that we can keep the momentum for hepatitis B PMTCT. Slide, please. And PMTCT can be considered like a entry point for hepatitis elimination intervention. When we have tested a pregnant woman, we can, after this, take this opportunity to expand testing to the family members by the strategy of family testing. Also, we can treat all of them who will be tested positive, and also it is a strong argument to test and treat other people either for HBV or HCV. We are thinking that we should push strongly on PMTCT to take this opportunity to expand other hepatitis intervention. Slide, please. It is my last slides, and I'm going to thank my colleagues from Afro Regional Office and also from HQ for their support on the preparation. Thank you very much. So I'm going to leave the floor to my co-chair, Danjuma. Okay, no problem. Have some issues. So when I'm waiting for Danjuma, I'm going now to leave the floor to Françoise. Françoise, you have the floor. Françoise is the PMTCT focal point in Afro region, Afro office. So I'm going to have the floor now to present on PMTCT. Thank you. Françoise, have the floor.
OK. Merci beaucoup, Casimir. Bonjour tout le monde.
Thank you very much, Casimir, for this invitation to present our experience in the fight against the PMTCT. It's a pleasure for me and an honor to participate in this summit about hepatitis and to discuss how can we have all this information and all the and especially for me, how can we effectively for the elimination of the vertical transmission of hepatitis in Africa. May I have my information? Thank you very much. Next slide. As I was saying, what are the things that we have? In this slide, I can show which are the countries that are already recognized, validated, who validated the PMCTC, the syphilis, congenital syphilis. And maybe you remember that in 2015, it was a new world that Cuba inaugurated, and they have eliminated of this the PMTCT, and it's not a question that Cuba was validated, and Cuba was followed in 2017 for 6 countries, and which countries proved that they could eliminate the mother-child transmission, and especially HIV, and for the transmission, congenital transmission. As you can see, the 15 countries are out of the African region. And next slides. In 2000, we saw the very first country in African region, and it was Botswana. And this we can see in this slide the celebration of it wasn't a very special event that it was celebrated in Botswana, but it was also celebrated in everywhere in Africa. And we see His Excellency and the regional Machitizomo, the certification for the elimination of silver level. The Botswana, it's a country for very touched by HIV, very high level, and for the we have more than 20% of HIV in women, and it's a very to have this state, to be in this crisis and to eliminate this transmission mother to child. It's a very big effort, and we're going to see later that Botswana was. They're going to tell us they're going to achieve this this vertical transmission. Next slide, please. And Botswana was validated for the elimination path. What can we understand? It's a concept dedicated to for the countries that are very high prevalence, controlling and it was these countries for the won't eliminate totally, but they can control the transmission, and this transmission in wealth in healthcare system. It's not a real problem, but a real menace of public health. The WHO, they dedicate the bronze stage, and the second stage, it's a silver stage. It's the stage reached by Botswana, because Botswana had the silver certification for and the last stage for this elimination, it's the gold that proves that the country is really advanced, and they're eliminating totally. Each step has a different content, very clear for reaching these levels of performance with public health in laboratories and data and of the respect of human rights, especially for the people living with the HIV and participation of different communities. And so OMS, the WHO, they have all these documents and to give those different guidelines for this elimination or this path of elimination. The first document that you see on your left side, it's the package. Elimination of mother-to-child transmission that and it concerns also the different criteria for the different indicators of impact and process to be certified for the bronze level, and then for silver or gold levels. In 2021, and this guide, it's with hepatitis B elimination for this PMTCT that can help the countries for a little integration of different of this elimination of the different illnesses. But mother-to-child transmission, VIH, syphilis, and viral hepatitis B. Why? Maybe you're wondering why we don't put the disinfections on together. They have different common points that are going to justify the different strategies, similar strategies, the common strategies, but the cost effectiveness of these strategies. And the first example, the 3 infections are sexually transmitted. The 3 infections can be transmitted vertically to mother to child, and the 3 infections have different challenges, and these are mortal infections, and the 3 infections are really silent, and they have a very strong evolution for the women are touched by different hepatitis, syphilis, and maybe if the healthcare services are working on the different testing and screening, they're going to have different measures to control it. And maybe more, my strong message is that the 3 infections can be really identified during latency, and they can be controlled and prevented. And so, and here I would like to insist that concerning hepatitis B, the African region has to raise, and because we have a menace, more than 82 million people are living with hepatitis B, and we have different types of, but the hepatitis B is are dying of this with cirrhosis and with cancer, liver cancer, and they didn't know that this can be avoided. And this work during and with the prenatal with the different services, care services, and people are dying within the productive age, simply because we didn't have health services, and we didn't have we have today the evidence, numerous evidence that the transmission mother to child, it's really high for hepatitis, viral B hepatitis. And my message today, and I'm going to say my recommendations as WHO, these different services for pregnant women, the screening, and it's a very important point for this consultation for all the women, all pregnant women, and every eligible woman pour HBS can be, as Casimir said, different quality services for the newborn. But this also has to reach the newborn, and we have so many countries that didn't have this vaccine to the newborns, and we cannot miss this occasion to avoid mortality. And WHO insists in the importance to raise awareness, and all this African region have to be that we have a menace, and that this menace of hepatitis, viral hepatitis B, and that the communities have to know this information. And this summit is a very important, capital importance to avoid the vertical transmission of hepatitis B. And to conclude, in African region, we have a very special chance to intervene, to help our continent to have a new generation of children that will be in good health, and that can be developed, and that they become to adulthood in our communities, in our countries, using very simple. If you have to get just one message from my presentation, it's the intervention for HIV, hepatitis B, and syphilis. We have all the means necessary to do it, and you're going to see, as Casimir said, for hepatitis B, we have everything can be used during pregnancy. And for HIV, it's only one retroviral per day to eliminate transmission. And for syphilis, one single, and we're going to cut this transmission with just one syringe. And 5,000, we can avoid the millions of deathborns, and we're going to have this liver cancer and this cirrhosis that are going to kill people in adulthood. And finally, today we're speaking about integration. This triple elimination, it's the approach that we need to propose to show our performances in terms of integration capacity and using synergies, and to have different methods in HIV are already proven their effectiveness. And so the triple elimination, it's the right path to follow. It's a message that we have to have. And to conclude, it's a call that these countries all shown some different progress, and I see that that are ready to go to the elimination path, that are considering their expertise to evaluate today the syphilis and viral hepatitis B. Maybe we're going to see that some of these countries are going to be validated for hepatitis B before HIV, and we have different countries that we have that have made this colossal work because of their system. It's not capable of prove their performance, and I would like to finish showing our commitment, and the WHO and the validation team for this elimination has already enlarged to include hepatitis B and syphilis, and all the partners are together, and we have only to have all this technical support and financial support to this and the last, and we have the luck. We are lucky to contribute and for a new generation in Africa, a new generation that can believe they're going to contribute to develop of our countries. So this triple elimination, we're going to prove that health systems are and public health systems, and we will have our impact, and we've shown in every country. So if you want to have more information, I have more slides that on the criteria, and we are available to continue with this. And thank you very much for this opportunity. Thank you, and have a good meeting.
Thank you, Françoise, for this nice presentation.
Merci Françoise pour cette
showed us how to leverage the progress made in the HIV and syphilis elimination pathway in the context of hepatitis B PMTCT. Thank you for this. And also we can understand that the prevention is the most effective intervention for HIV, syphilis, and hepatitis. And the path to elimination of those three diseases is possible in Africa region. So one of the points you have raised is that the quality newborn care should include the hepatitis B birth dose vaccine in the 24 hours. It is why Dr. Gillian now will go to present us the place of Hep B vaccine as in the effort of the triple elimination of HIV, syphilis, and hepatitis. Dr. Gillian, you have the floor.
Thank you, Dr. Kazimi, and good morning and good afternoon or good evening, everybody. So thank you very much. I'm Julien Kabore, and I'm the regional focal point for hepatitis B immunization in the Afro region. So, and just to pick up on what was said by Dr. Casimir and Dr. Françoise, prevention is the key for elimination of hepatitis B. And the prevention goes through the birth dose vaccine of hepatitis against hepatitis B. And I'm going to show where we stand in Africa with regard to that vaccination and how we can really move forward to help to move forward for elimination. Next slide, please. And this is just to repeat and to give the background, and I think Kazmi already mentioned that before. The world has reached a prevalence of less than 1% of chronic infection among children less than 5 years of age in 2020. And all regions have reached that except the Afro region that is still at 3.53%. And that's shown in the table on the left side. And when we look at the prevalence of chronic hepatitis B among children less than 5 years of age, we look at it by country, and I think Kazimi mentioned it before. Only about 14 countries have reached 1% or less than 1% of prevalence among the children. So that's about one country in four in the region. So that means we still have a lot of work to do. And next slide, please. And that can be explained by the coverage of the birth dose vaccination in our region. As you can see on that graph, that is showing the bars, the blue bars are showing the number of countries that have introduced the birth dose in routine immunization. And we have currently 14 countries and that have data shown here, but Burkina Faso just introduced the birth dose in April, and I think there will be somebody from Burkina Faso that will talk about that. So currently then we have 15 countries that have introduced the birth dose. And as you can show, starting in early 2000 up to now, the uptake of the vaccine in routine immunization has been pretty slow. We started with 3 countries in year 2000. By year 2004, we had about 7 countries, and we didn't have more countries introduced up to 2013. And we saw that the curve is going up, and we hope that it will keep going up with the uptake of the vaccines. And as you can see in the red line is showing the coverage in the region, and we are actually at 6% coverage in the region. Next slide, please. So, and as we said before, we know that prevention, as Francois said, is key to the elimination of hepatitis B mother-to-child transmission. And unfortunately, we are still lagging behind, as I say. And there are studies that have shown a modeling study that were done by the De Villiers and colleagues to show the impact of introducing and scaling up the birth dose for elimination. And in this table, you can see that if we stay at the status quo where we are right now, with the coverage we have at 6% for the hepatitis B birth dose and 72% for the 3rd dose of the vaccine, we won't reach elimination until after 2100. So if we include the birth dose now in the whole region, and then we scale up the coverage up to 25%, we can only eliminate it, still after 2100. But if we scale the birth dose up to more than 90% and more than 90%, we can reach elimination by 2059. And also there are 2 other scenarios that are showing with the scale up of the 3rd dose of the hepatitis B vaccine. If we scale it up to 100%, we can reach elimination quicker with the birth dose scale up to 90%. Then we can have an elimination, we can eliminate by 2054. And when we add the treatment of the moms that are eligible, we can reach elimination by 2049. And again, this is modeling data. It's not real data, but it's modeling with what data is available now that was put in the model to give those estimates. So we saw from here that we still have a long way to go, and we need to really boost and try to increase the birth dose uptake in the region. Next slide, please. So how can that happen? How can we do that? We need to accelerate the birth dose introduction in the region. And doing what? By doing what? We have to advocate for national commitment. And how can we achieve that? We need to gather data on burden and affection and risk of transmission, because one of the issues in our region is that we're lacking data to even show the true burden in the region. And to do those, to gather this data, this evidence, we need to do sero surveys among children, among pregnant women, And we can use other ways to really gather data through sero surveys to make sure we can get the data for advocacy. And also we need to work with the national immunization technical advisory groups that are the groups that are to look at the evidence and recommend the introduction of the vaccine in the particular country. So we need to also advocate with them, and they can also recommend that study be done so that they can look at the evidence to make sure they can recommend the introduction of the vaccines. We also need to look at the stakeholder. We need to engage all potential decision makers, including within country diverse area, including the Ministry of Health and Finances, because sometimes in countries we don't include the Ministry of Finances, but when there is a decision to introduce the birth dose, we really need to include those decision makers in the discussion so that they can help really to get the vaccine introduced. We also need to engage with the professional societies and associations that are within country or even across the region to make sure we can really push and we can advocate to really get these national commitments. We need to engage the non-governmental organization, the community leaders, the religious leaders, and all type of leaders that can really help to push for the cause of the vaccination in country. And other groups such as cancer prevention groups, chronic disease, and safe motherhood, and other organizations as well. Next slide, please. Now, as you see, the coverage of the vaccine is very low in Africa, so we need also to scale up the birth dose vaccination in those countries that have introduced or that are that have already introduced the vaccines. And for that, we need to develop clear policies and guidelines for the birth dose deliveries at the national level, as well as the local level, the district level, and the regional level. And these guidelines should specify the clearly timeline for the birth dose delivery and who can administer the vaccines, and really insist on how to report the administration of the vaccine. Because at the end of the day, those are challenges we have seen on the ground that hinders really the vaccination coverage. And the second point that is no less important, and even one of the more important points, is to integrate the birth dose vaccination with the newborn care policies and practices. And I think, like earlier, Dr. Francoise mentioned that we need to integrate that in maternal and newborn care activity package. And that will be really the best way where we can really get timely birth dose administered to all the kids without exceptions. And we also have to develop, and for that we have to develop and adapt the standards and the guidelines. You know, we have to develop that in the service deliveries, the manuals. We have to look at the job aids and poster where we can really update those standards and add the way we can work together on that thing, as well as the training material. And all, of course, all relevant staff should be trained on the policies and recommendations and documentations. Next slide, please. So in conclusion, what can I say? We can say really that the birth dose is needed, as we said, for control and elimination in the Afro region. However, we're really lagging behind, so we really need to push for this introduction in the region. So, and we need to accelerate the uptake and scale up to meet the elimination target. We need to engage the decision maker to ensure commitment for the birth dose introduction. We need to develop and adapt policies at national, local level to scale up the birth dose coverage. And we need to adapt clear strategy for the delivery in health facilities as well as home birth, which is really high in our region. Next slide, please. And thank you very much for your attention.
Thank you, Gillian, for the nice presentation, showing the importance of uptake of birth dose vaccine to improve the the newborn quality of care in all of our countries. So we're now going to see what is being planned by Africa CDC for hepatitis B PMTCT in Africa. I'm going now to leave the floor to Bibi Nafisa Shotum, who is the focal point for hepatitis and chronic disease in Africa CDC. Dr. Bibi Nafisa, you have the floor.
Thank you, Dr. Casimir. Thank you, Dr. Françoise, Dr. Julia aussi, for setting the stage and really highlighting this major public health threat that we're facing with Hep B PMTCT so far, and really the progress that has been made by some of the countries. It has really been a great session, and although I've worked in this field for more than 10 years now, I'm always learning something new from experts such as yourself. Hi everyone, I'm Dr. Nafisa Choton. I'm the unit lead of endemic and neglected tropical diseases under the new division of disease control and prevention at the Africa Centers for Disease Control and Prevention, or Africa CDC for short. I really apologize. I hope you can hear me clearly. I'm actually homesick today, but I did not want to miss the opportunity of being part of this panel. It is really my honor and pleasure to give an overview of the Africa CDC perspectives on the activities that we're planning around HPV PMTCT as we're starting work in this field, actually. And I really want to thank the organizers and my dear colleague, Dr. Casimir, as well, for his invitation to be part of this panel. Next slide, please. Thank you. So I'll start just by giving a brief background on Africa CDC. So as some of you will know, we are the health agency of the African Union. We were established in 2017, so we celebrated our 5th year anniversary this year. So we are a fairly young organization. And to put things into perspective, Africa CDC was actually established, the establishment was catalyzed by the Ebola outbreak in West Africa. So the first divisions, the first work that was being done was really around emergency preparedness and response, surveillance and lab, to really cater for outbreaks and pandemics, such as the COVID-19 pandemic, which we've done incredibly well. And lessons learned from this pandemic have allowed us to revisit the vision that we have for the continent and to come up with this new public health order for Africa that you see on the screen now. However, the idea behind Africa CDC was always to have an agency that could tackle the main killers on the continent. And as we're conscious of that, in the middle of the COVID-19 pandemic in October 2020, the Division of Disease Control and Prevention was established, under which there are 3 units. And the one that I'm leading at the moment is the unit of endemic and neglected tropical diseases. And our objective is to support member states with building and strengthening capacity to eliminate and eradicate endemic and neglected tropical diseases. And again, we know that, viral hepatitis has been a neglected disease on the continent. We always talk about HIV, TB, malaria, but what about, the silent killer that is viral hepatitis? So our decision was to really make our program on viral hepatitis our first flagship program. And I'll be presenting that over the next few slides. Next slide, please. Thank you. So we currently have a partnership with the Korean International Cooperation Agency for a 4-year program that is funded and that will focus broadly on data collection, development of strategies and technical documents, followed by implementation of surveillance systems in 5 member states. So we'll talk about, capacity building, all the way from screening to providing palliative care for people with, terminal liver disease, etc. And some of you will have seen the same presentation last year because we were meant to start implementation then. But we encountered budget and administrative issues that you always see with these organizations, but we've sorted them out now. So I'm happy to say that we are on track to start implementation this year, and we've already begun discussions with our colleagues at WHO, at CGHE, et cetera, to see how we can work collaboratively on this major public health issue. Next slide, please. So just to zoom in on our activities on around PMTCT for Hep B. So as has been clearly stated by the previous speakers, one of the main issues identified has been around even the reluctance to introduce, birth dose vaccine has been the lack of evidence to support introduction of this vaccine. Even though we know it, as practitioners, somehow to convince the policymakers, you really have to have concrete data. And I think that has been missing, for most countries. We have a lot of modeling data, but not really first-hand data. And there's been a lack of evidence of, that perinatal transmission in children. So what we're planning to do in the medium term is to conduct serosurveys on Hep B in 5 member states, 1 per African region. And we start small so that we can build obviously on this to support more countries. And we intend to first use historical samples that will be representative of the general population, including different age groups. And this testing will provide us with evidence of prevalence of Hep B in young children as well as in women. And where Hep B has not been introduced, this information can provide us with that baseline data so that we can compare prevalence in similar age groups after introduction of the birth dose vaccine. And these data can be used to support introduction of Hep B birth dose vaccine, not only in the country where these studies have been done, but also in neighboring countries that have similar epidemiological profiles. And importantly, we can use the data to perform economic evaluations. So when Julian was saying, we need to include the Ministry of Finance in our discussions, you can, when you have data, when you present them with data that makes financial sense, you can really drum up the political support. And longer term, we also want to establish a surveillance system within these 5 member states, which will allow them to monitor and evaluate their vaccination programs. And provide evidence of reduction of disease burden after the introduction of birth dose vaccine and other PMTCT interventions. Because as we know, even in countries where you have introduced the birth dose vaccine, it is not, it is not immediately a success story, because we also face problems with being able to administer the vaccine within 24 hours of birth. So these data will be critical to highlight where we need to focus our interventions and which groups need to be targeted more. Thank you. Next slide, please. Thank you. So before we go on to do the serosurveys, to select these 5 member states, because this is the question we get the most, how are you going to select, these countries? So we first are going to do a situational assessment and analysis in all the 55 AU member states. And that will help us, first of all, of course, to improve accessibility to national plans, but also assess countries to see which ones are more ready or likely, for introduction of birth dose vaccines, which ones already have PMTCT programs, for other diseases. Essentially, this assessment will provide us with key information on the gaps faced by countries, where the technical and financial supports are required, and importantly, what structures are already existing for other diseases that can be leveraged and that can be integrated to support HPV elimination. Because we're not here, to come and create another vertical program. We really want to create new programs that cut across and integrate existing structures, use existing personnel, so that, this can be implemented and owned by the country itself. We also intend to obviously build capacity to support countries to continue regular surveillance activities, to assess impact on introduction of interventions being implemented for Hep B, PMTCT, and of course train healthcare workers on PMTCT, depending on where the gaps are identified. Next slide, please. So some of potential activities that we're thinking about and that, are sort of beyond this, I don't want to say the scope of this 4-year program, but that, we don't necessarily have funding for, but we are working towards acquiring funding so that, we can also implement side by side. We include some genetic studies where we really want to leverage on capacity that has been built on the continent in terms of sequencing capacity, even RT-PCR capacity for COVID-19, and use that to characterize the Hep B strains in circulation, to identify, to do genotyping, to identify vaccine escape variants, and drug resistance mutations. A lot of the healthcare workers that I speak to, or even practitioners will tell you, we don't have capacity, to do genetic studies, on the continent, but this has changed now with COVID. And we really need to make sure that, we make use of this as there's momentum as we've trained more people to perform molecular studies, let's use them to now, tackle our endemic diseases. And this is an initiative that the Pathogen Genomics Institute at Africa CDC has started doing for malaria as a sort of entry point. And we expect to be able to use that capacity for Hep B genotyping and viral load testing as well. And we're also looking at using community healthcare workers that have been trained during and hired during this COVID-19 pandemic to raise awareness, around Hep B birth dose vaccine in the community, raise awareness around, with expectant mothers so that they can request, this vaccine. And we're also exploring the possibility of using midwives to vaccinate, neonates within 24 hours of birth. And we're looking to work with countries that have already done this before so that we can identify the best model of care that could be replicated elsewhere. Françoise mentioned earlier, Botswana is the first African country to be validated on the path for HIV elimination. And I believe, I can actually be corrected if I'm wrong, but I think Botswana is one of the countries that actually uses midwives for Hep B birth dose administration within 24 hours of birth. And one thing that I haven't mentioned here, but I really just want to highlight very quickly, this is my last slide, is that, we're also aware of the mental impact that this disease has, because most, cases, I've worked with patients before who are really trying to understand where they acquired this disease and why them, why not someone else. So there's always that, not just the stigma, but also, the acceptance that of this disease and how to manage this going further. So we are working to assess, the level of counseling that is available for Hep B patients and how we can provide them with, that psychosocial support. That's it. This is my last slide. I want to thank everyone again for the opportunity of presenting to you. Next slide, please. I just want to share my email address as well, in case, there are questions. I'm happy to take them, after, during the Q&A session. And if there's anything, you please feel free to contact me. I'm always happy to work and collaborate with everyone working in this field. Thank you. Over to you, Casimir.
Thank you very much, Nafisa, for your presentation. You give us the perspective from the Africa CDC on viral hepatitis prevention and control program. Thank you. And I think that one of the point you have raised, very important, is how to use the midwives to involve them in the Hep dose vaccination administration before 24 hours. It is very critical because when we give the administration is done after 72 hours, it is not enough efficient. So thank you for this point. I think that countries should see how to seize this opportunity. We are now going to the next presentation done by Dr. Mohamed Al-Bouraï, who is the Egyptian Initiative Director. He will develop on where we are now with the Egyptian Initiative in Africa. 2 years ago, during the AU presidential of the Sisi, President of Egypt. It was launched this initiative to see how we can provide treatment to 1 million of Africa people. It was a good initiative. So it is important for us to see where we are now and where we can go now. Dr. Mohamed, you have the floor now.
Thank you very much, Dr. Casimir. I'm really happy to be with you today to present about the Egyptian presidential initiative for treating African hepatitis. This was declared by President Abdel Fattah Sisi in 2019, and we had some achievements in 2019, but we stopped during the COVID pandemic, and then we resumed back late 2020. So in the next few minutes, I will present the initiative and what we have achieved in some countries. My name is Mohammed Al-Burai. I'm the director of the Presidential Initiative for treating 1 million African hepatitis C patients in the Ministry of Health and Population in Egypt. So, as all of us know, around 58 million people are infected with hepatitis C according to the WHO estimates in 2019, and around 10 million of those are present in Africa. Egypt has long way with the battle with hepatitis, especially hepatitis C, and we have reached the most valuable step through screening more than 60 million Egyptians for hepatitis C, aiming at detection and treatment of more than 5 million hepatitis cases to reach the goal of HCV elimination in Egypt. The objective of the initiative declared by President Fattah al-Sisi was to transfer the experience of hepatitis C screening and treatment to other African countries. And this will be done through training physicians, laboratory teams, and IT personnel, and providing the laboratory facilities by hepatitis C virus RNA testing kits, aiming at providing treatment for around 1 million African hepatitis C patients. This is an example of the treatment unit, the specialized treatment unit that we use in Egypt, and also that we have used in some countries. We have a small place. We don't need a very specialized place, just a place with a waiting area and 1 or 2 clinics, one for the examination, the other one maybe for the ultrasound, another administrative room to keep the files, a small laboratory and a pharmacy, and a unit for keeping the information. At the beginning, we planned to target 17 to 18 countries, and we held a meeting in Cairo, sponsored by the WHO in July 2019. These were the countries targeted in the first phase, and we were sending Egyptian teams to the countries that have responded to the initiative. We started in South Sudan in late 2019, and we started in Chad 1 month after, and also we started in Eritrea in December 2019. We have also received responses from some other countries, and we are working on that now, and we aim at the end to cover all the African continent by the initiative. So what are the responsibilities of the Egyptian team? We cover the travel expenses for our teams, and we partially supply the rapid diagnostics and HCV RNA testing kits and other laboratory parameters if they are not available. And we supply the treatment for all diagnosed patients. We give the combinations of hospivir and daclatasvir, and we give training for the healthcare workers. What are the achievements so far in hepatitis C? We have 3 visits to Chad, and we have established with our colleagues there around 29 screening sites, and we screened more than 27,000 citizens. We treated 427 patients. In the Republic of South Sudan, we had 2 visits, and we have established around 10 screening sites, and we screened more than 14,000 citizens and treated 169 patients. In Eritrea, we have 1 visit only, and we had 2 screening sites, and we screened more than 10,000 citizens, and 77 patients have been treated. And as you see here in the first picture, we are collaborating with the WHO in each country, and we formalize the visit by doing a usual joint plan between us, between the experts in the hepatitis management in the country, and this will be supervised by a WHO office. Regarding hepatitis B, we had also some screening and treatment for hepatitis B in Chad. During the visit, we have screened more than 15,000 citizens for hepatitis B, and around 13.9% of those were positive for hepatitis B surface antigen, and around 1.3% were HBV DNA positive. And in the Republic of Sudan, during our South Sudan, we screened more than 400,000, and the percentage for hepatitis B surface antigen positivity was 8.3, and for the hepatitis B DNA was 0.4. Thank you very much for your listening. This was the brief introduction about the achievements that we have done over the past 2 years. Over to you, Dr. Kazemi.
Thank you, Dr. Mohamed, for your rich presentation. We can understand that from this initiative, we have now 3 countries on board, and we are planning to go further. And we have almost 700 in of patients treated for hepatitis C. And we have also a good collaboration with the WHO country offices in the three countries. Also, not only for Hep C, but you are also helping countries about hepatitis B. I think that it is very important for this initiative. Thank you for your presentation. You understand that we should be more aggressive, so to improve the ownership of communities and population. It is why now we are inviting our colleague Theobald, who is from Ghana, who is the World Hepatitis Alliance focal point in the board for Africa. I'm going now to give him the floor to say something about the contribution of the civil society in the efforts of hepatitis B PMTCT efforts in our region. Dr. Theobald, you have the floor. And I would like to remind that if someone would like to ask a question, don't forget to put in the chat box so we can use them at the end. Thank you. Dr. Theobald, you have the floor.
Thank you, Gasmalo, and good morning, everybody. And I think you have increased my title to doctor this morning. I'm not a doctor, I'm a Mr. Theobald Uswansan. And maybe maybe you are a prophet, so in future I can become a doctor in future.
Yes.
Yes, this morning I'm going to talk about civil society contribution to mother-to-child prevention of hepatitis in Africa. Next slide. Please, next. You know, for the past 15 years to 20 years, CSOs play a vital role in supporting hepatitis B and hepatitis C. And also, they also support mother-to-child prevention. And they have advantage over public providers because they can reach more people than public providers. And they have been a forefront of hepatitis response. They play a critical role in global fight against hepatitis by serving as a bridge between policymakers, members of the community that are affected by hepatitis. And the civil society also play critical role advocacy. In terms of advocacy, they provide enable environment for mother-to-child transmission. Next slide. What WHO elimination goal? By 2030, they want to reduce incidence by 90% and also reduce mortality rate by 65%, and also try to cover about 90% of birth dose, and also less than 1% of or less than 5% of people get infected by hepatitis. Next slide. So here I won't talk much about it because my other colleague have already spoke about it. So I will just jump into the next slide. What the global needs? What do we want? We want to increase hepatitis B service to grassroots level. We want to increase access to birth dose. We want to increase access to birth hepatitis B testing. And we want to increase access to hepatitis B treatment. You know, some of us, like myself, I'm a patient, I will always want to get access to treatment, affordable and quality treatment. And also, we also want to track the progress of accountability. The NGOs is like watchdog. They monitor policies. They make sure the government is accountable of what it's doing. Next slide. And we have to also, you need collaboration between the civil society organization, the policymakers, and the funders. And the viral hepatitis funding is very sufficient and to meet current goals. And country-focused elimination plan for viral hepatitis include mother-to-child prevention efforts and guidelines for management of hepatitis B. When I started my foundation in 2008, there was no policy, or let me say guidelines in Ghana. So through advocacy, Minister of Health in 2016 and 2014 were able to implement policy to tackle hepatitis in Ghana. And also we train workforce and with capacity to manage and diagnose and treat hepatitis B. As I said, what Hepatitis Alliance are able to do all these things through their members. When I started the foundation, we have to move to the northern part of Ghana to build the capacity of most of the healthcare professions, because that time, when you tested positive, they don't know how to manage it. So a lot of people were just going to the herbal clinic and other services, which was not helping the matter. So train healthcare professionals to build their capacity has been what the global needs now. Next. What are the CEOs doing? They are the front workers. As I said, they are providing service where government cannot provide service to them. And they are also advocating for policy reform to create awareness. And you know, there's a discrimination against people who are living hepatitis in Africa. And they are advocating for reform for human rights and human rights, and also building capacity to support community need and organization and also groups. Next. What civil society can do, or what are they doing, and what can they do? First, advocacy. Putting pressure to government to create elimination plan. Advocacy to include resources for prevention of mother-to-child transmission, including birth dose, and also testing. Ensuring leakage to care service for anyone testing positive, and ensure protection against discrimination for anyone testing positive, and also to fight back and report discrimination. And also ensure cold chain equipment and resource for training healthcare providers involved in labor and delivery, and also to what to understand, and also the barrier to administration of birth dose and work towards identify barriers. Next. In terms of advocacy, we are also advocate in collaboration with government and civil society for Gavi to support birth dose and also provide insights of treatment and testing, and also supporting awareness campaign and direct reach out. And also as accountability, we serve as a watchdog and monitor implementation of prevention and control activities. And also resource mobilization. We also help to organize education, train people, organize testing, and also getting funding to support government elimination plan and policy review. Some of the NGOs, they have capacity, that they have some special profession they can help to review most of the policies. So they are also helping policy review and also capacity building. They build most of the patient group, they build their capacity so that they can fight for their rights. And also healthcare professionals, they go to other rural areas to build their capacity to handle hepatitis cases. Next. In conclusion, I believe civil society organizations can amplify the voice of patients, defining their human rights and demand that their concerns are addressed. Next. And food for thought. Do we ensure that their activities are regulated and streamlined, especially related to prevention of mother-to-child transmission, screening, vaccination, treatment, and linkage to care? Yes, I think so. They have to regulate their activities because now most of the civil society have moved to political or let me say business aspect of their job. So we need to streamline their activities. Next. I will end my presentation with my mentor. One life begins to end the day we become silent about things that matters. So hepatitis is we need all to come together as Africa to eliminate hepatitis. And I want to quote this. Just first, Danjuma said, "Who cares?" The civil society, we care. That's why we want to partner with government to eliminate and also introduce birth dose in Africa. Thank you very much.
Thank you, Theobald, for this great presentation on the role of civil society in the hepatitis B PMTCT efforts in Africa. Yes, who cares? Civil society can care, do something for it on advocacy. To mobilize domestic resources, advocacy to the financial partners, but also insight on barriers to testing and treatment, also the accountability, how to raise the demands, but also to take care of human rights aspects. Thank you for this, and it is a big recommendation in the country to see how to get involved the civil society in the effort at national level. Thank you for this guidance, my brother. So for now, we are going to the second panel. About countries, on the countries, the frontline countries, implementers countries. So I'm going to leave the floor to my co-chair, Dr. Danjuma, who is the World Hepatitis Alliance elected president, who will be chairing this session. Doctor, you have the floor.
Thank you. Thank you, Casimir. Good morning, good afternoon, everyone. My apologies for being slightly late to join this session due to technical issues. And it's been wonderful to listen to all the presentations from the Egypt to the Africa CDC to the WHO Afro Regional Board member and all the panelists. So we're going to the countries panel, and we're privileged to have great speakers that will share their experience on what they do at the country level. So we're starting with Maria Emmanuel from Burkina Faso. She's going to talk about resource mobilization for HBV PMTCT, and she's from the Ministry of Health, Burkina Faso. So Maria Emmanuel, the floor is yours.
Ok, merci Danjuma de me passer la parole.
Thank you, Danjuma, to give me the word. I'm honored to share with you during this World Summit the experience of Burkina Faso regarding the way we finance the struggle against viral hepatitis, in particular in the case of mother-to-child transmission. We have to mention that viral hepatitis have been for a long time neglected, and that it has been recently that they've been tackled by two resolutions at the level of the World Health Assembly in 2011 and 2014. And we really appreciate the fact that a global strategic plan has been adopted with as a goal, main goal, the elimination of viral hepatitis by 2030. Burkina Faso is a West African country where a bit less than 21 million people live, and where we have a quite high prevalence for hepatitis B of 9.1%, with transmission from mother to child hepatitis B rate of 2.6%. In the case of hepatitis C, the prevalence is 3.6%, but with two particular regions with a higher prevalence of 6.17 and 13.18%. Among the topics I'm particularly interested in today is the financing or funding. Regarding the transmission, mother-to-child transmission, we in the country have a national strategic framework that is financed. The global budget is evaluated at a bit less than 8 billion CFA, francs CFA, which are $13 million. I think there are problems with the audio. And that funding is mixed. It tackles not only hepatitis B, but also HIV and syphilis. And an involvement and engagement from the Global Fund is also included in that funding for the period from 2021 to 2025. Inside our national strategic framework, we have included this point, the fact that 95% of pregnant women seen in their prenatal centers are screened for the 3 illnesses, and they all benefit from the same screening for the 3 pathologies: HIV, hepatitis B, and syphilis. And it takes place at the moment of the consultation. It's an integrated package that eases the financing of a big part of this process on the hepatitis side of that elimination plan. Regarding vaccination, it's really recently that our country, Burkina Faso, has introduced the birth doses since April of this year. That activity is financed on the state budget at almost 80% and with other partners for 21%. Regarding the vaccination at birth in particular, not the whole elimination process and programs, it's a 100% state budget finance. Gavi also helps and has a perspective to support in the coming years. There are some gaps we have to fill regarding that financing aspect, because not all segments of the population are taken into account, like the mass screening, the wages for different other health personnel. So there are some aspects we have to better or to improve in the future. As a conclusion, we have determined that the prevention of mother-to-child transmission and vaccination are essential links to achieve the objective of elimination of hepatitis by 2030. Funding is still a major challenge, and we need to find innovative financing strategies through a better involvement of states and communities, and the integration between hepatitis and HIV and other sexual transmissible illnesses are a great opportunity to move forward in our country. Thanks a lot.
Thank you, Emmanuel. Thank you so much for this beautiful presentation. So we still want to tell us that we'll soon go to question and answers, but if you have questions, you just drop them in the chat box and we'll take note and we'll come back to respond to that subsequently. We're going next to the Sierra Leone experience. Dr. Nadeg Mofopa, she talked about viral hepatitis B and C among Ebola survivors and healthcare workers in Makeni, Sierra Leone. Thank you.
Greetings to you all. I would like to thank the organizer of this great summit for the opportunity given to present on viral hepatitis B and C, infection among Ebola survivors, and healthcare worker of the Makeni city in Sierra Leone. The outline would be as follows. Viral hepatitis B and C account for the most viral hepatitis morbidity and mortality globally. They are responsible for about 1 million deaths occurring yearly in the world. Africa bears a substantial portion of the global burden of this infection, with less than 2% of diagnosed cases and less than 1% of infected persons being on treatment. It is reported that approximately 2 million healthcare workers are infected with HBV worldwide, and exposure rate around 10% in Africa. Sierra Leone is a low-income country of West Africa that has experienced a long decade of civil war with a real and a great devastating Ebola epidemic with a real impact on its health care delivery services. The country currently has no nationally representative data to guide the diagnosis, management, prevention, and control of viral hepatitis. Few studies have shown a significant variability in the prevalence of HBV and HCV among subpopulation groups within the country. It is reported that the prevalence of hepatitis B varies from 8 to 21%, while that of hepatitis C varies from 2 to 8%, though we were able to have up to 26% of positive hepatitis C cases in Ebola survivors enrolled in this work. The objective of this study were to determine the prevalence of viral hepatitis B and C in Ebola survivor and healthcare worker of the Makeni town in Sierra Leone, and identify knowledge and awareness gap in healthcare settings. We carried out a cross-sectional study during the last 2013-2016 Ebola outbreak, where we enrolled 68 Ebola survivors with an average age of 13 years and 81 healthcare workers from 2 healthcare facilities having an average age of 39 years. We define an Ebola survivor as a person who was infected by the Ebola virus, presented signs and symptoms of the disease with a positive PCR test, and later on recover. Healthcare workers were identified as individuals who work in healthcare settings, including the administrative board, the cleaner, the driver, the security personnel, and community health worker. We use the ELISA technique to detect HBV marker and anti-HCV antibody in the study population. We were able to search only for 3 HBV serologic markers because of limitation in reagent, that is the surface antigen, the antibody against the surface, and the core protein. The positive detection rate of each marker in Ebola survivor was respectively 23%, 32%, and 88%. We also assessed the seroprevalence of current HBV infection and recorded up to 38.99% in Ebola survivor. We noticed that 16.66% of survivors were considered immune due to past infection. Of the 81 healthcare workers enrolled, the positive detection rate of the surface antigen, the antibody against the surface, and the core protein were respectively 37, 33, and 30%. About 4.94% of these health staff were doing current HBV infection and we had up to 23 that were considered immune due to past infection. Those immune due to vaccination represented only 2.47%. As we stated previously, some study has demonstrated a high discrepancy as far as hepatitis C seroprevalence is concerned in Sierra Leone. Data from what we did shows that hepatitis C prevalence in Ebola survival was up to 26.47%, with about 10% of co-infection with HBV. Meanwhile, this prevalence among healthcare workers was 2.47%, with less than 2% being co-infected. It is known that healthcare setting plays a major role in disease dissemination due to high-risk occupational exposure to bloodborne pathogen. Knowledge on viral hepatitis B and C among healthcare personnel of the Makeni district in Sierra Leone remain problematic and shows significant gap. Although we were able to show in this study that 64% and 49% of health staff had adequate knowledge on the clinical outcome of viral hepatitis B and C, only 28 and 17% knew their serologic status respectively. We also noticed that less than 50% of participants enrolled were aware that there are antiviral treatments for hepatitis B and hepatitis C infection. About 50% of health personnel had adequate knowledge on the transmission route of viral hepatitis B and viral hepatitis C viruses respectively. Thus, the necessity to raise advocacy for the implementation of strategies that enhance community-based screening and specific treatment programs in the country. Although the Ministry of Health and Sanitation in Sierra Leone has implemented the vaccination program against HBV infection in infants, most is still needed for the general population and health staff as well. The fact that 53% of health personnel were aware that there is an effective vaccine against hepatitis B did not have an impact on their vaccination coverage. Most of them became immune, that is about 23% due to natural infection, and only 6.17% had received a vaccine against hepatitis B. However, serologic evidence of past immunization through vaccination was present just in 2.47% of health staff, meaning that there is no provision for routine immunization service for healthcare workers in Sierra Leone. We conducted this study within the framework of implementing routine healthcare services for Ebola survivors and healthcare workers living in areas with poor medical coverage. Although the study was limited to Ebola survivors and confined only to 2 healthcare facilities of the Makeni town, finding demonstrated significant knowledge gap and high disparity in the burden of viral hepatitis among the various subpopulations. That's the reason why prospective, nationwide, and representative survey are needed to understand the true burden of viral hepatitis in Sierra Leone. Efforts should also be directed toward the understanding of the prevalence of this infection in high-risk groups like sex workers, drug users, genitally mutilated women, and also patients on hemodialysis. We also believe that to achieve the 2030 target, there is an urgent need to establish some elimination strategy like the prevention of mother-to-child transmission program, the implementation of the immunoglobulin and birth dose administration together with the infant vaccination calendar. We also suggest that it is the case with HIV, national program of viral hepatitis B should consider the test and treat approach for all infected patients. Once more, we would like to thank the organizer of this wonderful summit and all those who contributed to this work. Thank you.
All right. Thank you so much, Dr. Nadeg Mofapa. Thanks a lot for that beautiful presentation of the experience in Sierra Leone. It's quite disturbing to look at, to see here that there's no provision for HPV vaccines among healthcare workers in Sierra Leone, among other issues you brought up. So, and we're glad to have you also in the panel to respond to questions that may arise from your presentations. So we're going straight ahead to the last part of this session with Dr. Bonaparte Nkomo to talk about the experience, Botswana experience. And it's good to listen to the pioneers of HIV elimination in Africa. What are the lessons that have been taken from your experience, which can also accelerate the elimination of hepatitis B? So Dr. Bonaparte Nkomo, the floor is yours. Thank you. And over.
Thank you very much. Good morning, everyone. Good afternoon. I'm going to take you through our brief presentation on the Botswana lessons from HIV elimination to the accelerate hepatitis B elimination. Next slide, please. Yeah. So, as we have said, I'm coming from the HIV division. So we are leveraging hepatitis B elimination on the HIV elimination that we have just achieved. Just to take you through a brief on our HIV statistics. We are a small country. We just had the census, and it has shown us that our population is just over 2.3 million. But it's a small population, but the spatial distribution of this population makes health services provision not be a challenge. So we have an estimated HIV population, people living with HIV of around 380,000. That's a huge population if you consider that this is about 4 times the population of Seychelles. And we have about 330,000 people on ARVs. And we just did our equivalent of the population-based AIDS impact survey, or what we call Botswana AIDS impact survey bias. And it has shown us that our HIV prevalence is at 20.8% for those aged between 15 and 64. And this survey has also shown us that we have achieved our 95 targets at 95 for the first 95, 97.8 for the second 95, and 98% for the third 95, well ahead of the target of the UN target of 2025. The HIV incidence from spectrum estimates is below 1%, and this bias has also shown us that it is indeed below 1%, around 0.2%. But we have done also some other surveys, the Botswana Behavioral and Biological Surveillance Survey of 2017, which has shown us that we have very high HIV prevalence amongst key populations for female sex workers, around 43%. And as everyone now knows, we awarded by WHO the silver tier of Path to Elimination of Mother-to-Child Transmission of HIV. Next slide, please. So that is the entry point. So this award did not come that easy. So the process itself, the validation process itself, started by us coming up in October 2017 with a national validation committee, coming up with the terms of reference for this committee, the appointment of members, defining their roles, of course, with the assistance of WHO and other UN organizations. And the chairperson of this committee was not coming from government, but from our NGO partners, and also the deputy chair. The government was mainly part of the secretariat. And then, of course, we had to look at our Botswana data and use Spectrum to see where we are. And of course, through and through, we're assisted by WHO. And in October 2018, we conducted a self-assessment, which was shared to WHO and the regional office for analysis. Next slide, please. So this slide here is just showing the timelines for the validation. The process really started around November 2020, and it's quite an involved process with the recruitment of consultants, gathering relevant documents, doing a desk review, adaptation of our EMTCT tools, training of data collectors, pre-testing of tools, doing very involved field work, and then doing data analysis and report writing, and then presenting our results to the National Validation Committee, and then getting the Minister of Health to sign off. And then between May to August 2021, the regional validation team was looking at our data. And between September to October 2021, the global validation team then looked at our data, and that's when we were given the award, which was received by His Excellency in December 2021. Next slide, please. So the indicators that really landed us on the silver tier award were as follows. So if you look at our prevalence, maternal prevalence from our program details around 26.5, of course, that was coming from our Sentinel survey of 2015, 26.5, was quite a high maternal prevalence. 2019, using the estimates, is showing that we are at 22%. And then in terms of impact indicators from our program data, the MTCT rate was at 0.5%, and then the case rate was below 500, actually 393 for 2019. So our assessment was for 2 years, 2018 and 2019. And then our ANC for the process indicators, our ANC coverage was above 95%, and then our testing rate above 98%, and our ART coverage above 97%. So we also had some results from the spectrum modeling, which are shown, and the slides will be shared. Next slide, please. So our PMTCT success has come because really everything is led from the highest office in the land, the office of the president. There has always been that strong political will. I think we can cite all the three presidents that we have had in the last three presidents. All of them have had all the interest in the PMTCT. And also government funding has ensured that there is sustainability. And government funds, provision of ARVs, provision of infant formula, and other commodities. And there is always that quick response to all the changes that come from the global arena, from WHO, from AIDS conferences and everything, as shown by our move to option B plus, treat all, and all that has contributed to our successes. There has been a lot of investment in capacity building on the health workforce. So there's a lot of trainings for the workers, refresher courses. And we do have motivated PMTCT focal persons at the districts who really own the project, own the program, and run with it. And they are also facilitated with things like laptops, projectors, and now we are trying to ensure that they do get these dongles so that they are connected in case we have virtual meetings with them. We also try by all means to capture our data and monitor, do a lot of monitoring. Or we must admit that we really have to still improve on this. Next slide, please. So, what have we learned from the national validation process? Like I said, our national validation committee was made of critical different skills mix with a lot of people coming in from civil society, from our partners, from community members, representation from people living with HIV. There's a lot of consultation what involved also the leadership, be they from our development partners or from the ministry. And then we have been quite flexible. If we have any findings, if they are adverse, we always accept them and try to work around them so that we can improve on them. So we must emphasize that the pre-assessment is very key, your own assessment, because it really gauges your readiness and is able to assist you in working out whatever is needed. I have to really talk to the political commitment that is critical in the national validation. But we must say that we have learned a lot through this process of validation. The issue of sensitivity to human rights, gender equality, and community engagement. I think this process really has taught us that this elimination is not only about technical clinical work, but it also involves all the other people like civil society and members of the community. And as I've said previously, really, data quality is very important. And we still using manual tools, and at times we need to verify our data to improve. So the national validation process is really quite an intense process with a lot of technical involvement, and also it is also financially stressful. There is a lot of money that is involved. Next slide. So just to take you, to give you an idea of where we are with the hepatitis B activities in Botswana. So from our blood bank, of course, we do test the 4 pathogens, hepatitis B, hepatitis C, HIV, and malaria and syphilis. So our hepatitis B prevalence at the blood bank is around 1%, 0.8%. That translates to about 200 people. And if you think that these 200 people have contacts, it means it's quite a number of people. And remember, this blood bank is a low risk, these are low risk people. So we have also done the BBSS surveys on key populations. And they've shown us that amongst female sex workers, the prevalence is around 4.2%. But we have a district in Northwest Botswana, which has very high prevalences for female sex workers, around 10%. For men who have sex with men, while the country prevalence is 4.6%, in this district is around 15%. And then also we did an STI microbial survey, and it did show us that the national prevalence is at 3.7%, but this very district also in Northwest Botswana has a very high prevalence of 8.2%. We are conducting vaccination for hepatitis B for health workers and emergency attendants like the police, ambulance people, and all the others who attend to emergencies. And we also give a birth dose, as was indicated. We have been giving the birth dose from year 2000. And then we also give the 3 doses of pentavalent. We are in our HIV program, ARV guidelines, we are testing for hepatitis B for people initiating PrEP, and also this is supposed to be a baseline investigation for people initiating ARVs. I must say we do have challenges with the testing, but that is what we are supposed really to be doing. Unfortunately, we are still working on our viral hepatitis strategy for the country, but in line with the recommendations from the global community, we hope that this strategy will be combined with the STI and HIV strategies in one. So our viral hepatitis activities at the Ministry of Health are in three units: child health, the STI program, and occupational health. But we in the country acknowledge that we have got very strong partners who are into viral hepatitis research. These are NGOs, and we hope to leverage on their strength to strengthen our country strategy. Next slide. So going into triple elimination, we have already adopted as a country the triple elimination of mother-to-child transmission for hepatitis B, syphilis, and HIV. We are hoping to strengthen our birth dose vaccination and strengthen our booster penta doses with improved supply chain and recording. We also hope to strengthen our hepatitis B testing for antenatal care mothers, and we are working on introducing the dual and triple combo kits, which can test for HIV, syphilis, and hepatitis B. And we really want to leverage on the strong HIV ARV programs to make sure that our viral hepatitis program is strong. And like I said, we are working, we are asking for the assistance of WHO and other UN agencies to assist us with coming up with our joint HIV, STI, and viral hepatitis strategy. As a country, we are working together with development partners, the private sector, and our CSOs in triple elimination. And we recently had a visit from the UN, from WHO, UNAIDS, UNICEF, to come and assist us with the roadmap for so that we can go to the gold tier or elimination of mother-to-child transmission. So this visit was in May, and I think we are really assisted, and the assistance continues on mapping out how we reach the gold award by 2024. And just for information, our president has said that he wants to receive that award in 2024, and he has asked us to say what is it that we need from him so that we can reach he can receive the award in 2024. Next slide. So I'd like to thank you, and just maybe to mention that the bias survey that we concluded in 2021, we have some repository specimens. We are actually thinking, because we don't have the country prevalence picture, we are thinking of using those repository specimens to check for hepatitis B and C. And also, I think there has been a proposal to say we could also check for the protection against hepatitis B for children who were involved in that survey. So it's something that is proposed and we're working on. So we really think that as Botswana, we can work together as a country, and by 2024 have our president receive the Gold Task award, and also get our children free of HIV, free of syphilis, and free of hepatitis B. I thank you.
I mean, this is awesome. Dr. Bonaparte, you got me really thinking. And as you got me really thinking about the situation in Africa, and as an African, I get disturbed to see the appalling attitude of our leaders, and all that you have said and the presentation about Botswana boils down to leadership commitment. And that is why you even talked about government funding to sustain the work. That is awesome. And I just hope other leaders we have in the region would really replicate what the leadership and the president of your country is doing. I wish I could just stretch over and give that your president a handshake and say kudos for the great work, because that is fundamental towards all the success you have achieved. Leadership commitment, that is driving the whole thing. And kudos to all you, the team members that are doing that. And I think we have a lot to really learn from Botswana, the systems, the domestic financing, which is very fundamental to us sustaining what you're doing. So thank you so much for sharing. And I'm happy that WHO is here. They heard your plea for support to develop the viral hepatitis strategy. We have the focal person for Africa, Frank Lule, is there. We are, for WHO, we have Casimir here. And we have the entire WHO listening to you that on the beautiful one. So we're now going straight to the question and answers. And I hope all the panel members are there. So Casimir, I'll hand over to you to kickstart the question. Then I'll also join. But thank you so much, all the speakers, for the great presentations.
Fantastic, dear colleagues and presenters, for all experiences you have shared. We receive some comments from Frank Lule. He was thanking Theobald for the great overview of the importance of civil society. From Françoise, good presentation from civil society organization. Question: how civil society and hepatitis alliance are leveraging on existing HIV community-based organization? Can we have examples of collaboration between the two communities? What partners can do to strengthen? What partnership we can do to strengthen synergies and communities and civil society organization? So, Theobald, I would like to give the floor to you to respond to these first points. Theobald, you can unmute your mic. Yes.
Okay, thank you for the question. And this question
You are
is
muted.
Okay, can you hear me now?
Yes, we can hear you, Theobald.
Okay.
Oh, okay. I think this question is about 3 questions, and I will answer the first one. And since my president is here, I would like him also answer the second one, the examples, because I just took the mantle just a couple of months ago. So he has been there for so many years, so he will answer the second one. So leverage on existing HIV community-based organization. HIV have a lot of community based. So what we are doing is that what we have done is that we are advocating for other HIV groups to integrate hepatitis program into their program. Because you know, hepatitis and HIV is like a brothers and sisters, they move together. So we are advocating that if they can also integrate their programs, a hepatitis program to HIV, so that in the community they go, they can also create awareness and also screen people on hepatitis and HIV. And also, we are also identify regions where we don't have hepatitis advocacy group, and those HIV organizations, if they can also integrate the hepatitis program into their program, so that they can also create awareness and advocacy there. As some, like Danjima was in HIV and later on he had hepatitis, other NGOs was in HIV and later on they had hepatitis. So we are leveraged on their existing programs to also do advocacy and also creating awareness. And as I said, so Danjuma, if you can answer question, the example of collaboration between the two organizations, because you have been there for so many years.
All right, Civil, thank you. There are so many examples of collaborations we've had, and I think you rightly mentioned the common areas of convergence between HIV and AIDS. And I'm happy that the current GHSS 2022 to 2030 looks at a people-centered approach towards delivery of healthcare services. In Nigeria and in my state, Taraba, we do, in fact, most of the community screening now, you go in the name of, you're doing wellness services or hepatitis, and then you do HIV screening into it. And again, using the HIV diagnostic platforms, we're beginning to adopt that in my state, Taraba, using the gene experts, of course, with TB, and then the HIV to run hepatitis diagnostic testing. So these are areas, and then the reporting. Like I'm happy that like the military is supporting the government of Nigeria to adopt tools where in reporting the indicators, you have one tool that reports all the indicators, right, from the testing, the care, and the management, so that you don't have multiple documents and papers that you need to report on tools. So that makes seamless reporting, even at the healthcare facilities. And now we have test kits that use almost 2 or 3 rapid testings for HIV and the hepatitis B. So I think it makes a lot of work. It removes barriers patients experience so that you have one-stop shop where a person goes to the facility or even at the community work and you're doing testing, you are providing both HIV and hepatitis. And then, so that's really good. In fact, in some communities in Taraba, we motivate people by giving them hepatitis testing, and we're now bringing HIV into it. So there are several areas of collaboration. Then, but most importantly, is in the area of financing. Hepatitis is like the small boy, the small child who is in rags, like my mentor Charles Go said. But you know, the HIV have the money, so sometimes we want to grab the HIV people and say, please, can you just carry us on your back because of the funding, like the global funding, which has to do with comorbidity issues. So these are areas of collaboration. And the systems, you discover the HIV organizations have been there for long, so they have more strong systems. And so the hepatitis is really trying to adopt some of those, like look at the Botswana experience, have very strong monitoring and evaluation systems, which the hepatitis can really emulate. So a lot of areas of collaboration. Community activities can really bring this integrated approach. You do HIV, do NCDs, do hepatitis, so that you're giving a complete package to populations that you're serving. Thank you.
Okay, thank you, Robert and Danjuma, for these great points. We have also a comment from Chukwemeka, who has appreciated the presentation done today and showing that timely birth dose is crucial to achieving WHO targets. And also understand you raised the fact that the limited funding remain a crucial barrier and is much needed to move the need and Afro on the path of achieving HPV-free generation. From Jennifer, come back to what about funding. Please consider that the domestic resources is a very big starting point. You can see the example from Botswana, also from Burkina Faso, where the government accepts to fund in Burkina Faso to buy to purchase the HPV vaccine, birth dose, and from these partners can come and to build on it, because they have now a promise from Gavi that for the next 3 years they can support it. But it is important to continue to work on it, and civil society is very important for this advocacy. From Jennifer, I understand that we have a survey. Thank you very much for your great presentation. I would like to ask for your help with initiative at ICE HBV to improve HBV care in resource-limited settings. Please consider filling out the survey and sharing it with your colleagues who also work on HBV in resource-limiting settings. The survey is now in French, English, Spanish. You can visit the ICE HBV booth to learn more information or download the survey. Thank you for Jennifer for this advocacy. Also for Divai Elmali, we received the good and informative presentation. The funding has to be liberal for MTCT all over the world. The timing of birth dose makes a very crucial part when the child is born for HIV positive mothers, and follow-up of the child is the other important for elimination. Thank you for all your inputs, and from Moko, very happy to read your comments. WHO is looking forward to supporting Botswana develop a viral hepatitis strategy. Thank you for all these questions. I don't see other question, but I would like now to leave the floor to Danjuma for other points. Thank you.
Oh, thank you, Dr. Casimir. My question is to Dr. Nade for the presentation on Sierra Leone, the experience there. So you said there's no provision of hepatitis B vaccines among healthcare workers, and does Sierra Leone have a hepatitis strategic plan? Dr. Nade again.
You are muted.
So, okay, so the question goes to Dr. Nade again. Nadej, sorry, Dr. Nadej. My sincere apologies for my appalling pronunciation. You mentioned the no provision of hepatitis B vaccines among healthcare workers in Sierra Leone. So does Sierra Leone have a hepatitis strategic plan? And so, yeah, does Sierra Leone have a viral hepatitis strategic plan? Thank you.
I think she's not online.
She is online. Okay, I see Dr. Frank raised his hand. Dr. Frank, go ahead.
Yeah, thank you so much, Danjuma. Just to answer that question for Sierra Leone, I know they may answer it better, but yesterday I received a message. The Ministry of Health is requesting WHO to support them to develop a comprehensive multi-year plan for the viral hepatitis response. So they are aware of the high burden as was presented, and they're actually taking steps to develop a strategic plan. Thank you.
Thank you, Dr. Frank Lule. It's a pleasure meeting you again through this platform. And that addresses the question. So, Dr. Casimir, back to you.
Thank you, Danjuma. I don't know if we have Dr. Mohamed. Are you online? Dr. Mohamed from Egyptian Initiative. I think that we have lost the Dr. Mohamed. So we are now at the end. We are now at the end of the meeting. We can keep some key points for this from this session. That the PMTCT is a very important intervention for hepatitis B elimination. It is also a low-hanging fruit for our activities, because we have existing services in what we can on which we can build our hepatitis B PMTCT program. And the quality of pregnant women in antenatal care services should include Hep B testing and treatment, and the same for the quality for newborn care, which should include also the Hep B vaccine. And we have, until now, we have only a few countries who have already integrating the hepatitis B BEF dose, only 14, and with Burkina Faso we'll do 15. And also we note that we have some partners very active in this setting, like Africa CDC, who will be working with us in this setting. And we note also that the midwives should be involved in the administration of Hep B BEF dose vaccination. It will be very important to be sure that administration is being done on timely when we want. Also, the political commitment is crucial. We can see the good progress, the great progress from Botswana, and the president is committed to get the gold tier on 2024, not only for HIV, but also for syphilis and hepatitis. I think we need this leadership in our countries. Also, we can see that it is possible to mobilize domestic resources to procure hepatitis B BEF dose vaccine. It is important, and after this, we can see other partners to support this initiative. And we can also understand that the civil society, the involvement of civil society is crucial in our program. We can see what we can learn from the PMTCT evaluation program evaluation in Botswana, that it remain many challenges on human rights, gender equity, and community involvement. So it is important from now to involve civil society in our activities and go to and progress together. So advocacy to raise the demands and human rights accountability, we can work together with the civil society. Thank you, dear colleagues, for your participation. Thank you for your inputs. Thank you for your availability, and thank you to be our voices in your respective countries, so we can push PMTCT and make the difference. Thank you. Have a nice day. Goodbye.